Welcome friends once again to our NPTEL MOOC module on health economics. So what you have inferred out of our previous week lecture, it was on theory and principles of economic evaluation. So in this one, we'll be identifying each of the directions, monetary as well as non-monetary measures of health. That's why it is part 1 of the lecture. Once again, I'm just recapping what we did it in the earlier week. We learned about the theories of economic evaluations. We also discussed about principles of economic evaluations. There are 5 approaches we discussed. Those were cost benefit analysis called CBA, cost effective analysis called CEA, cost utility analysis called CUA, cost consequence analysis that is called CCA, and cost minimization analysis called CMA. If you remember, last two we said less used, especially CCA and CMA, but we discussed in detail for your reference that might be specific situations where you might get interest to apply, and we have given its nomenclature in detail of the methods in the previous week. Within each of these, we emphasize their definition, objectives, features, use of the principles with relevant example, their advantages and their disadvantages, including the limitations. In this lecture, we are emphasizing on the specific aspect of evaluation. We learned in our initial lectures of the course that in health economics and outputs as types of output in healthcare, precisely that's on amount of healthcare provided or health itself. And in this one, hence we will be focusing on how is each of these output or their types measured and used in economic evaluation. As you know very well, these are largely subjective in nature. Healthcare as a concept defining an output in production function is very challenging. You need to derive the specific type of measurement, then you can define their whether this measurement in follows continuous or a discrete choices. Okay. So, and how the measured output is valued in monetary terms and not just counted are going to be discussed. Unlike the other areas of economics where measuring and valuing the output is used to be pretty straightforward, and there possesses no conceptual difficulty, but in healthcare industry in particular there are challenges. For example, in an industry such as pharmaceutical, output is measured in physical terms such as quantity of goods produced and value based on market value of good. Output measurement and valuation in healthcare industry is indeed difficult. Such questions are like now is it the number of treatments of the industry or in healthcare, or it is the improvement in health. And further, if it is the health improvement, how it can be measured and valued. So, we will learn how economics measure and value healthcare output or benefit. Broadly, these are divided into two. One is called monetary valuation, another is called non-monetary valuation of those outputs. So, let us start with the discussion of monetary valuation of healthcare output. You just recall what we did in our CBA method, that is called cost benefit analysis method. We emphasized the concept called willingness to pay, or even sometimes it is called willingness to accept. This is a means of capturing benefits and cost in monetary terms. This provides the basis for measuring changes, the welfare or benefit for changes in cost due to resource allocation. Further, we also introduced you to the approaches that use the theoretical concept of WTP, willingness to pay or accept, in practice to measure their benefit. So, the method is WTP. There are two approaches in fact we follow usually or authors follow. that are called revealed preference or stated preference approach. These approaches are the ones that adopted or adopt the monetary valuation in healthcare benefits or output. So, we will explain one by one, starting with the RP, that is revealed preference approach. This refers to the monetary valuation of goods and services based on inferences drawn. Okay, so first aspect is the inferences drawn. Okay, so we are actually mentioning inferences drawn, this part, from the real world choices. So, what is happening around is more important. Hence, a person while evaluating for certain access of services must have done certain possible calculation in his or her mind, and based on that real choices, real world options availability, hence the opportunity cost is usually derived in the minds of the people. Hence, people make choices based on their preferences by comparing the alternatives with their alternatives with their opportunity cost, which I just said. The choices they make therefore reveal their preferences. What they mention is actually a revealed one, because they already made certain calculations. Someone is I mean, we are just citing one example for a case where if someone is not willing to purchase a treatment that is costing 20 rupees per unit. However, and if the person knows that somewhere 10 or other options are available, so person might be willing to do that treatment at the half the cost of that available treatment. Hence, we can infer that the value of value that person places for the treatment lies between the range of 10 to 20. So, varying prices within this range help estimate their maximum willingness to pay. Okay, so the availability and the willingness can also be calculated based on certain revealed preferences and estimations. The above example reveals that individual choice. However, we are more concerned with estimating the value of some good for everyone who consumes it. In this example, the average willingness to pay can be inferred from the market demand curve using same reasoning as for individual consumers demand curve. Okay, so there are some challenges lies, as I already said, estimating the options availability, and the challenges with the RP is that, especially in healthcare industry, prices are not charged directly or do not reflect the value. So, the prices which just quoted in the example may not be directly observed, and they are free at the point of consumption or highly subsidized in number of cases. These poses difficulties for estimating the demand curve, because there are different schemes available, and since it is one of the important aspect of public policies. However, if someone is interested in health improvement instead of health services, then we cannot use RP, as health improvement cannot be traded and hence no market. Okay. And what then in that case, what are the solutions for it? There are two options at this moment, either user cost method or through indirect market method. We need to consider the additional costs, such as travel time, travel or the time required for consultation, etc., associated with obtaining that particular service. Even if the service itself is free, but the other costs are directly borne by the individual or the person. There are indirect cost or a market method as well. This infers benefits from market assessing to the related outcomes, such as the income of the people who work high risk job compared to those who work in the low risk job, and can infer about their change in income. So, that is all about the revealed preference. We are now discussing the another approach of this, which have already started, of the willingness to pay. Okay, so we are now discussing about the SP, the stated preference. So, stated preference valuations are derived from surveys or experiments. These surveys or experiments are often loosely termed as willingness to pay studies. Here researchers might ask people to give values directly or directly or infer them indirectly by offering hypothetical choices. Okay, so choices uh, can be hypothetical because we are expecting their preferences, and the assumption is that this valuation lies on the assumption that values that people state really reflect their choices, and choices that people make in the survey are the same they will make in the market. So, whatever they reflected in the survey should be same finally to reflect in the market demand curve. The foundational basis for this approach to be validated is unlike the revealed preference that is based on economic reasoning or the estimations, preliminary observation. The main theoretical basis of the stated preference is largely psychological. Although controversial in nature, most economists accept the use of stated preference technique as long as consistent with the aim of the economic analysis. So, this is accepted by the most of the studies. So, the valuation techniques used for the stated preference are broadly some techniques are taken like survey method, simulated market method, contingent valuation method, and DC method or discrete choice experiment. So, in the surveys, basically the referendums on different issues are addressed, and some authors such a we are referring to simulated market. You can also follow from Bhatia and Fox by 2003 paper. In this, the goods are actually provided under experimental conditions. So, using some simulated techniques, contingent valuation and discrete choice methods are also used, and especially in contingent valuation, that is as I already mentioned, widely recognized technique. It refers to the valuation of goods and services where the measurement of the value is contingent on the descriptions of the hypothetical market that is given to the respondent. So, the complete understanding or the description that is given about the the hypothetical market is more important, whereas in case of discrete choice, this is considered to be the very recent addition in the valuation techniques, and as part of the stated preference. Though as I told you, the last two, that is contingent CVM and DCs, are the most used or the recognized techniques. We will understand these in health market in detail. So, contingent valuation, once again, as I told you, the contingent details about the hypothetical market should have been provided. So, the features such as we need to understand their credibility, ensuring respondent understands, then also representative sample. We will discuss one by one. The most important issue while applying contingent valuation is ensuring the credibility, that is the values those are reflected should actually catering to the real choices, and the respondent must understand the market scenario that are presented to them, and they must find plausible and meaningful. Without this, it might be difficult for the respondent to answer and may not give the serious response. For the essential requirement for the descriptions should be sufficient, understandable. As I told you, the plausible, the meaning, etc., regarding nature of the goods and services, and also relating to the credibility of the figures that are reflected by the person. However, the information provided must be as minimum as possible. Overburdening or irrelevant instructions through so many details might be putting the persons to reflect non-credible information, and surveys information might be not be appropriate enough for the real world situation. Last one as part of the CVM is of representative sample. This representative, the sample where we are actually deriving must be representing enough to the larger population. it makes sure that the sample used is representative to everyone who might be affected. So, we have to take such coverage of the sample, that way it must actually be replicated in different situations. So, the approaches especially in healthcare are challenging, as I already told you. Although there are no universally accepted approaches to CVM studies, Gaffney in 1991 has published a very strongly argued set of guidelines, which mainly include the following, that is, willingness in terms of insurance premium and realistic scenario, then effects in probability terms, then the representative sample which already mentioned in Gaffney's work. Willingness in terms of the insurance, how much premium one is paying. People cannot plan to consume healthcare, hence willingness to pay should be expressed as an insurance. They would prefer to pay for the service they need. And in the realistic cases, as I already mentioned, it has to be catering to the real scenario. The scenario should state the probability that they will need it. Okay, very probability should be very high. Okay, effects of probability terms, such as the effects should be explained in probability terms, then the probability of success or the failure, etc. Then the representative one, all the members of the population of interest is required, and then they must be representative enough. There are a number of challenges, especially problems attached with this CVM, contingent valuation method, in healthcare in particular. So, such as there are some artificial nature of choices made in real life. Consumers' choices consider the trade off between benefits and cost. However, in experiment or surveys, the environment is not an actual market, and largely hypothetical, and potentially influencing respondents' choice, and based on utility derived from the interactions with the researchers. There are strategic responding people, maybe quite prepared enough to get the best benefit out of it when they know that experiments are made, and if any policies are targeted, they reflect differently, they give strategic responses. Rational consumers may strategically respond in surveys, anticipating future receipt or payment obligations, or the potential provision of goods or services for free. So, they act accordingly. You might have seen in different poverty alleviation program, and some views are taken, they respond as if they are part of the model very clearly. Realism of market scenario, this ensures, this is the problem where ensuring realism of the market scenario is very critical and has many problems. Hence, what are the ways of asking questions related to willingness to pay? There are 4 ways in which researchers ask respondents to respond their willingness to pay. One is open-ended responses, then closed-ended, then payment scale, okay, or iterative bidding. Open-ended, basically you give the choices to write their view without any caption or without any limit, okay, and it is used to be very simple, and there are also concerns involved, like this deviates from the typical market behavior, and they may yield random and unrealistic responses because open choices are given. In the closed-ended responses, we need to specify within the limit of the responses, like in categorical values we give within the choices. Here respondents choose to accept, and in binary format, maybe accept or reject a single value, yes or no kind, or 1 or 0 kind, etc., or in a dummy format, and different values are presented randomly to different people in a sample. WTP values are estimated from average responses. Merits with this method is that this easily relatable to market with fixed prices for goods, and fixed components can be expected. There are also concerns attached with it. This provides only a single choice to individual, okay, where choices are limited. In the payment scale, a scale of choices for the extent of payment can be given out of the ranges, as I already said. This also gives certain extent of open endedness, and the potential concern for this is that the potential queuing on what WTP values are considered sensible to the researchers. And the iterative bidding is another aspect of WTP, where respondents in an interview engage in a bidding process. Respondents are initially given a price with the price adjusted based on their WTP, and hence the best choice is derived from the bidding, and this merit of this method is that this is closer to market operations by allowing handling. There are concerns attached to it, like this is restricted to interview settings and continues until the respondent is undecided. One of the example of WTP using the contingent valuation method mentioned by Morris in the work of 2012, Morris et al. Examined patients' willingness to pay for child safety seats in Iran. Iran has one of the highest rates of road traffic deaths rate in the world. Road traffic injuries are the leading cause of life years lost. Use of child safety seats is not mandatory. That is one case derived by this author and presented as a part of the expression for understanding willingness to pay. Hence the author interviewed 590 car owner parents of children under the 5 years in a preschool setting. So the experiment unit is in a preschool setting, and that to the persons are the one who have children under 5 years in total, and then they owned a car. Parents were shown pictures of the main types of safety seats, okay, and with evidence of their efficacy in reducing deaths and information on the incidence of child car passenger deaths in Iran. Using a payment scale format, parents choose the amount of money they are or they were willing at the time of survey, they were willing to pay for the safety seat from 7 options, whether safety seats are required and what much payment they are willing to pay, all measured in the year 2009 US dollar. Since the paper was published in 2011, this Jurahi paper 2011 mentioned by Morris work of 2012. Out of these 7 options, which one are actually best preferred, the results suggested that interventions providing free or subsidized car safety seats should be considered, given that the willingness to pay was lower than the actual price of safety seats in Iran. So, I mean the choices given as a willingness to pay is very low than that of the actual price for the safety seats. Hence, the idea is that as per the policy intervention, there must have been free provision of this to control the number of incidences, since years of life lost is very huge in Iran. Okay, that is a very interesting finding. You can also experiment on your own in different settings of your field, but make sure that must be representative enough, and the experiment you do must be understandable to the persons very clearly. And it is representative because pan Iran or even in the world this can be applied, where the incidences are largely high, they will follow this, and then to the number of prices models are also given and choices are taken for finding. Another one is called discrete choice experiment. So, contingent valuation method we have already discussed. We are discussing now the DC. DC are part of the stated preference SP, which already discussed. Technique use this is the techniques SP or the stated preference technique used by health economists, and this is grounded in Lancaster's 1971 theory. When you are writing your thesis on anything related to experiment, try to refer to the original theory. That is largely viewing the Lancaster theory is on viewing goods and services as bundles of attributes. So, goods and services basically is part of as a bundle of attributes. People's preferences for these attributes determine the overall preferences for a good. The stages especially involved in DC are largely emphasized in Ryan and Farah 2000 work. They have described the stages of conducting DC, which are as follows. There are probably 5 stages: to identify the attributes, to assign the level of the attributes, and to choose the scenario for the inclusion of those attributes and the persons to be experimented, and to establish the preferences through the DC, and finally the analysis using regression, sometimes use conditional logistic regression, because some conditions are given, we will discuss in detail. So, understanding how DC is commonly used, this involves presenting individuals with choices of scenario described by these attributes. For each choice, respondents are asked to prefer a scenario. Then respondents are asked to make a number of such choices. Respondents are modeled using regression analysis. Finally, the regression analysis actually helped identify the specific determinants and identify the factors which are actually largely impacting the valuation, and we can find out the trade offs between the attributes and determine the overall utility score for each of the combination of the attributes. And if cost is also included as an attribute, then DCs enable the estimation of willingness to pay for a good with specific attributes. Application of DC are here presented very in detail. Now, we are actually discussing in 2 contexts. One is for the context of the consumer or the patient, another is from healthcare provider or the doctors or the supply side perspective. So, it measures the patient preferences in various interventions. In an example like some of the contexts such as smoking cessation, pregnancy management, colorectal cancer screening, etc., as part of the consumer's perspective. And in some example for the healthcare provider like physician's perspective, such as preferences for oral versus intravenous drugs in cancer treatment, and the worker working in antenatal clinic, there are preferences for different malaria prevention strategies, especially in pregnancy, can be checked. Now, let us use an example finally to understand the DC application in health issues in particular, and we will clarify all other methods which we just mentioned, all those 5 methods. So, here is an example of the DC to assess patient preference for early rehabilitation management after stroke. We are referring to the Laver et al. 2011 paper, which specifically mentioned preferences of stroke patients for different models of rehabilitation in Australia in 2009 and 10. They identified from their review of literature that the attributes of stroke rehabilitation that were important to patients and that were capable of being influenced by policymakers. These were confirmed by patients in qualitative interviews, okay, and developed into 4 attributes with 3 labels each. 4 attributes are there, but each case has 3 attributes, okay, or 3 labels. Okay. 5th attribute, that is the cost, was also included to allow estimation of willingness to pay assigned to each label of each attribute presented. Here we can use the steps suggested by Ryan Farrer, the 5 steps which already said, to understand and the DC in detail. Starting with the step 1 and step 2 is all about identification and labeling of attributes, which you already discussed. There are 5 attributes and 3 labels each, as I already mentioned, as per the work of this by Laver et al., also emphasized in Morris. So, those 5 attributes are mode of therapy, dose of therapy, then team providing therapy, then amount of recovery and cost of therapy. The labels for each are like for mode of therapy, is it a group level, individual level, or it is computer level. Then dose is given, what is it, 30 minutes, 3 hours and 6 hours per day. For the same example which you already mentioned. Then team providing therapy, such as whether it is community doctor, physiotherapist, same specialist team or different teams for each phase, etc. Amount of recovery is given as 70%, 80% and 90%, 3 levels. The cost of therapy, the fifth one, which I already said, to measure the willingness to pay. Either it is no cost level or at least $50 Australian dollar per week or 100 Australian dollar per week is evaluated. For step 3 and 4 out of the 5 steps we already said, like for 3 and 4 are choosing scenarios for inclusion and establishing preferences through discrete choices. 3 levels for 5 attributes resulted in 243 possible scenarios, which were reduced to 18 choice sets between 2 scenarios. These 2 scenarios are divided into 3 different versions, each containing 6 binary choices. 50 patients in the full study, each patient made choices between 2 scenarios in each set. The resulting choice set for each scenario is as follows. For program 1 and program 2, you can see individual therapy, and in the case group therapy in the program 2. For individual therapy, 30 minutes per day, the cost is 100 Australian dollar per week, and same specialist team, and 80% recovery out of those labels which I have mentioned. Finally, the result is here. And the group 1, program 1 and program 2, group therapy 6 hours per day, no cost is preferred, and community based doctors and physiotherapists visiting 90% recovery, etc. indicators are derived. Using final step is to understand the regression analysis through the responses. Analysis are made through conditional logistic regression, analyze patient choices. Dependent variable was of course binary choice between program 1 and program 2 out of program 1 and program 2. So, hence it is a binary choice. The independent variables are the attributes labels for each program which I already mentioned. Hence the result and conclusion of this particular example are patients prioritized. So, actually those are divided into 2 programs, and finally results are derived. Finally, the results mentioned that patients prioritize 90% of recovery and individual therapy. Computer therapy, longer daily sessions and higher cost were less preferred. Willingness to pay related figures offered a quantitative understanding of the patient's preference for various rehabilitation attributes. The provided information is a concise summary of the key findings. For the further details of this, you can read the full study by Labor et al., which I already mentioned in our reference. That paper was in 2011, strongly recommended for better applications. So, that is all. I am just giving you the summary and conclusion of this lecture. It is indeed difficult to value output of healthcare, since it is complex and largely provided by public institutions and is part of public policy. Evaluation from as an individual as a part of cost or the willingness to pay is very tough, and there are 2 ways it is usually valued. One is monetary and non-monetary. Within monetary, for valuation of healthcare services, there are 2 methods we discussed. One is called revealed preference approach, and another is called stated preference approach. While revealed preference is based on economic logic, whereas stated preference has hypothetical foundations or psychological foundations. However, due to the unavailability of the market in health, stated preference is preferred, okay, to RP. You just check one second what do you mean by unavailability of market. We mentioned in that RP case and their limitations. There are various techniques of valuation under stated preference. Those who are out of those methods, to we emphasize, that is contingent valuation method and discrete choice method. So, that is all. What is following in the next lecture? It is all about the specific concerns related to health improvement, and we will also emphasize on the monetary valuation of healthcare outputs. which will include measurement of health improvement in terms of quality adjusted life years and daily adjusted life years. We have also used these two in other units as well, but the evaluation pattern etc. will emphasize now next lecture. We will explore further the concept of non-monetary valuations. All right. So, that is all. I hope you are geared enough for the next lecture and maybe ready for the questions, because we are going to set number of questions from these evaluation techniques, and we will also give you some important case where the best method can be utilized. So, appropriate case you need to identify. These references will be useful enough for you to understand further. With this, I think I should stop, and I hope you will raise questions. Thank you.